Looks like some people are still getting in, but we will get started. So tonight's lecture is given by Dr. Courtney, who is a board certified fellowship trained orthopedic surgeon who specializes in hip and knee replacement surgery. And his specific specialties are in partial and total knee arthroplasty, complex primary and revision arthroplasty of the hip and knee, periprosthetic fractures, and periprosthetic infections of the hip and knee. Dr. Courtney sees patients in our Northeast, Doylestown, and Center City office locations. We will be answering questions at the end of the lecture. There is a little chat box and also a Q&A box at the bottom of your screen. Feel free to use either of those, preferably the Q&A box, and we will read those and get all of your questions answered at the end. So you can take it from here, Dr. Courtney.
Thank you, Natalie, and thank you everyone for joining. Again, my name is Max Courtney. I'm one of the hip and knee replacement surgeons at the Rothman Institute. Hopefully you guys are used to some of these Zoom sessions by now. It's been great that we've been able to reach out to everybody virtually, that we can certainly capture a lot more people and answer all your questions. I will try to answer questions in the chat or the Q&A boxes, as Natalie said, as we go along. So again, please, you can try to make it interactive. Otherwise, we'll certainly get to questions. We'll leave some time at the end. So there's a lot of, my talk, as you see, is titled Myths, Marketing, and Modern Medicine of Total Joint Replacements. A lot of the stuff that you see, you might see on the back of the airplane magazines or on TV commercials or on even on certain websites. And there's a lot of myths and marketing materials out there about hip and knee replacements, and they're fantastic surgeries. And I just want to kind of go through some of the hot button buzzwords that you guys are hearing a lot as patients, and go through some of the data and what we have to offer at the Rothman Institute. These are my disclosures, none of which are relevant to the talk. So a lot's changed. There's common myths and conceptions that we're going to go about. There's many non-surgical and surgical treatment for osteoarthritis. And then we're going to go through some of the specific marketing and technology, some of those hot button buzzwords that we talked about. I think that the biggest change, if you kind of look at joint replacement from a 10,000 foot view, we've had a significant increase in volume, right? I can tell you, I tell patients when I was a resident, when I was training 10, 12 years ago, maybe we were only doing 2 to 4 joint replacements a day. And now most of our surgeons we're maybe doing 6 to 8 joint replacements a day. And that's because we've seen a change in demographics. We're doing a lot more joint replacement patients in younger patients as well. The rapid recovery protocols, which we're going to go through, have really revolutionized how we've done joint replacements. Certainly payments changed. Rothman has really been a pioneer in value-based care, especially as it pertains to hip and knee replacements. And there's a lot more technology that's now involved in how we do hip and knee replacements. I think one of the biggest things is total joint replacements. Again, used to be, people said, oh, it's only for old people. And again, 20 years ago, the average age of a hip and knee replacement patient was pushing 80 years old. And you would tell people you should not get your joint done until you can bear it. Wait until you can't bear it, and wait until you're in a wheelchair, wait until you're in a walker. And that's not the case. Today, again, I think age is just a number, and certainly we'll talk about different medical risk factors. But I tell people, you'll know when you're ready for surgery when it's impacting your ability to live your life, whether you are a runner, a skier, whether you like just taking walks with your husband or your wife, whether you like being on the floor playing with your grandkids, whether you're a golfer or a tennis player. When it starts to impact your quality of living, that's when you really should seek care and talk to one of us here at Rothman about what we can do to treat your arthritis. As we talked about, again, historically, joint replacement volume was lower. Again, if you looked at the number of procedures we were doing back in the 1990s, we're only doing, again, about 150,000 a year. And now, and this chart's even older, we're seeing more and more done. And if you look at the data in the United States, it's about 1.2 million joint replacements. It's 2 to 1 knees versus hips. So there's about 800,000 total knee replacements done in this country, and about 400,000 total hips done in this country every year. So again, that's quite a lot. And as we do more cases, we as a healthcare system, you certainly get better and more efficient. And we talked about the age difference. This is a chart looking at the percentage of people under age 65 that are getting their joint replacements. And again, even 10 years ago, again, it was less than 50% of people. And now if you look at the graph, a lot more younger people are undergoing total hip and total knee replacement. The other big thing that we've changed with the rapid recovery protocols is we're sending more and more patients home. And if you look at the purple line in this chart, that's the amount of the percentage of people that were discharged to a rehabilitation facility. Again, when I was training 10 to 12 years ago, everyone asked, oh, well, where am I going to rehab? And they would go visit a lot of the different rehab facilities. And we've done a lot of research here at the Rothman Institute that says that it's still safe for you to go home. It's even safer for you to go home afterwards. Going home after your joint replacement, you have a much less likelihood of being readmitted to the hospital, of going back to the ER. And depending on some studies, you may even have a lower infection rate. So we're really trying to push people to be able to go home, because we think it's better that you recover in the comfort of your own house as opposed to a rehabilitation facility. And if you can look at our data, again, even 10 years ago, IRF stands for inpatient rehab facility. That's the orange line on the chart. The red is a subacute or a skilled nursing facility. The yellow is home health. So we'd send you home with a home nurse or a home physical therapist. And then the green box, which again has become the majority over the last few years, is being able to send patients home. So even again, looking at over the last decade, only about 10% of our patients, it's even less than that now, if you look at some of the 21 and 2020 data of patients that are going to a rehabilitation facility. We're also sending people out of the hospital a lot quicker. Again, back in the 1990s, the average length of stay, this is an article from JAMA, was 9 days in the hospital. Even in the 2010s, a decade ago, the average length of stay was 3 to 4 days. And now in 2022, we're doing a lot of these as outpatients. Patients select healthy patients are able to go home the same day. And if not, most patients spend one night in the hospital, they work with a physical therapist, and they leave the next day. With respect to outpatient hip and knee replacements, and we'll talk about how we can do outpatient hip and knee replacements, but patients are asking for them. And especially during the pandemic over the last 2 years, a lot of patients were weary about being in the hospital, and they're worried about contracting COVID, and they would ask to go home. And we at Rothman have developed a lot of very mature now outpatient hip and knee replacement protocols. We have the one on the upper right is down at Atlanticare. If you're from down the shore, our specialty hospitals, at the bottom here, we have a specialty hospital in Bensalem and one that's in Limerick as well. And then we've also partnered with a company called Move Health that helps us run some of our ambulatory surgical facilities across the area. And we now have several across the Philadelphia and South Jersey area. And you're able to spend 2 nights in a care suite that you're just working with nurses and physical therapists as well. So this has been, again, if you look at the patient satisfaction scores, it's a nice experience for patients. Again, for select healthy patients that might not need a full service hospital. If you need to be monitored for your heart or pulmonary disease, that's a completely different issue. But most healthy patients are certainly candidates for outpatient hip and knee replacement if you're interested. So again, discuss this with your Rothman surgeon, and they're going to be happy to tell you the pros and cons about this. The big question is, so why are patients leaving the hospital faster? So one, I think it's, well, we do more joints, we do more joint replacements. We talk about volume, and as you do more volume, the surgeon and the system becomes more efficient. Certainly, I've become a faster surgeon now 5 years into practice, but the system as well becomes efficient. And again, I would tell you, wherever you seek out your hip and knee replacement care, the one common theme that I'm going to talk to you about during the course of this talk is to go somewhere that does a lot of volume. You want your surgeon that's doing, and all of our surgeons here are doing several hundred joint replacements a year, and that's all we do, right? Most of our surgeons, we don't do rotator cuffs, we don't do Achilles tendon repairs. I mean, again, sometimes if you're on call, very few of us are doing ACL reconstructions. We just focus on hip and knee replacements. And by getting that subspecialized care, that's really what, if you look at all the data, you go into a surgeon that does a lot of volume, that's just specializing in one particular thing, that's how you're going to be able to get the best outcome. The rapid recovery protocols, which we're going to talk about, I really think that's helped revolutionize that. And we work very closely with our anesthesiologists and our physical therapists to hone in our rapid recovery protocols in order to help patients get home and out of pain a lot faster. And certainly people are going home because the average age has decreased. We're seeing younger people undergoing hip and knee replacements, and that's helping their quality of life. And I think the increased awareness about health has helped, right? Again, 20 years ago, we didn't have Zoom talks that we were able to give to the community. We didn't have Twitter. We didn't have practice websites with information that people could go on. We have interactive platforms called Quill that the patients can look up home exercises and interact with their provider to ask questions. So there's certainly, especially in the digital age, an increased awareness about health. The rapid recovery protocols that we've talked about, again, 10, 12 years ago, everyone would get general anesthesia. So they would get intubated, that's a tube down their throat. The surgery would take a lot longer, most often 2+ hours. And now we're doing regional anesthesia, which is usually a spinal anesthetic and a nerve block. And our anesthesiologists have been really, really good. The spinal anesthetic and the nerve block has been great at helping keep people out of pain longer. You're able to wake up a lot faster. There's some data showing you're going to have less postoperative nausea and vomiting. And we just give you light sedation like you're getting a colonoscopy. So you're not awake here in any of the parts of the procedure during the OR, but you're getting just some light sedation. Periarticular injections. So we inject a cocktail of numbing medication around your hip or your knee joint after the procedure as well. And that helps ease the first 12 to 18 hours after surgery from a pain standpoint. And then again, 10 to 12 years ago, everybody got an IV morphine pump. Patients had respiratory depression issues. They were slow to get out of bed. And now we don't do that anymore. Everybody gets standing Tylenol. We give you an anti-inflammatory, either a drug called Celebrex or Mobic. A lot of our surgeons are using a nerve pain agent such as Lyrica or gabapentin. And then, yes, you do need a low-dose narcotic as well. Traditional pain control is reactive. So you would tell the nurse when you're in bed, when you have pain, you hit a button and you get pain medication. And that was the theory between a lot of the IV pain medications we have. The opioid pain medications, again, and opioid pain medications are certainly part of our pain protocol, and they're drugs that you've probably heard of, either Norco or Percocet. The oral pain pills are longer acting. The IV pain pills are shorter acting. In the multimodal approach to pain, you get medication before you have pain. So in most of our protocols, when you come into the hospital the morning of surgery, we give you these pain pills even before you have the procedure. So again, that helps. If you use the analogy of a plane landing on a runway, it helps smooth that landing. The regional blocks that our anesthesiologists doing are fantastic too. And we talked about that. So they're doing an adductor canal block, which is a needle that they place in the patient's thigh to help numb the nerves around your knee. And we talked about either the spinal or the epidural regional anesthesia to help with pain control too. Again, intraoperatively, these patients are also getting that periarticular injection of numbing medicine that we're numbing around the patient's knee. And postoperatively, we're giving all these pain medications as well. And this helps multiple things. So it helps that first 12 to 18 hours, especially if you're going to be going home the same day after surgery. So it helps facilitate discharge. So you're able to get up, you're able to walk, right? We're not going to send you home unless you clear physical therapy, but you can't get up and walk and move around if you're still in so much pain. And then the big issue in 2022, everybody's heard about the opioid epidemic over the last decade, is minimizing opioid side effects. So certainly you don't want to be getting hooked on narcotics. You don't want to be building up tolerance, respiratory depression, all of these other side effects, nausea, vomiting, constipation, and the multimodal pain protocol certainly helps mitigate that. The periarticular injections, we talked about this pain cocktail. Has really been helpful too. So most of the time your surgeons there's usually a long-acting local anesthesia medicine that they're going to numb around the joint capsule. And the benefit of a multimodal approach is all of these medications, whether it's an opioid or Tylenol or these nerve pain medication, which are called a gabapentinoid, they all act at different parts on the pain pathway. So that's why you're able to get all different types of pain medication, and you get it before you have pain. It's proactive and not reactive. A couple other things that have changed. I think our surgical wound closure has changed. Traditionally, we would use staples, and there's nothing wrong with staples. I'll still use staples on patients with thinner skin. But the daily dressing changes. You wouldn't be able to shower until your wound was closed. Now, most of us will use absorbable sutures, which are deep to the skin. The dressings are waterproof. They're more water resistant. So most of our patients are able to shower right away. And the dressing, more so than the dissolvable sutures and the glue, but the dressing, there's lots of good studies that a lot of these silver impregnated dressings have helped reduce surgical infection rates. So that's been helpful. And I think patients like being able to shower right away as well. This is, again, what an old surgical dressing was on the left. Usually we'd make you wait a week until the wound was dry to shower. And now some of the silver impregnated dressings, which have helped reduce infection rates. Now we'll go through some of the different non-operative and operative treatment options for hip and knee arthritis. And these are going to be, again, frequently asked questions that I get asked a lot in the office. A lot of patients will ask, well, can I take glucosamine and chondroitin? What's the data behind that? Is that going to be helpful for my arthritis? And the advantages, it's certainly not harmful. It may be good with patients who have early arthritis. I kind of think of it as like a joint vitamin. Unfortunately, not all brands are created equal. It's expensive. You're going to get these at QVC or a lot of times your local fitness store. The big thing is it's not FDA regulated. So it's not FDA approved as a drug. These are approved as supplements. So not all brands are created equal. The bar to get approved as a supplement is much lower than getting approved as a drug. And it can take several weeks to be fully effective. So the data is a little iffy on its efficacy. It is certainly safe. It is not harmful if it's something that you want to try, but just be aware of some of the disadvantages of glucosamine and chondroitin. There's topical agents. So there's topical NSAIDs. NSAID stands for non-steroidal anti-inflammatory drug. So there are downsides to taking oral NSAIDs, especially if you have heart or kidney problems. If you're elderly, you could be at risk for getting a gastric ulcer. So you can use these type of gels. Voltaren gel or diclofenac gel is a common one. And you get local penetration without the systemic side effects. So it's certainly a reasonable option, especially in somebody who can't tolerate anti-inflammatories. The lidoderm patches, again, these are temporary. They're not treating the inflammation, but they're certainly going to give you some local pain relief for as long as you have the patch on. The oral anti-inflammatory meds, and again, these are Advil, Motrin, Aleve, or all the trade names. Celebrex is the prescription anti-inflammatory. And there's concerns. We talked about, especially in elderly patients, you can get gastric ulcers. Certainly, if you're on prior blood thinners, if you have any cardiac history or kidney history, you should talk to your primary care doctor about being on anti-inflammatories, especially longer term. For Tylenol, Tylenol is a very safe drug. And there's regular strength, there's extra strength, and there's arthritis strength. And it's been, even if you have heart or kidney problems, this drug is also safe. There is a liver interaction. You don't want to be on more than 4 grams of Tylenol a day. If you do have liver disease, you should avoid Tylenol. And then alcohol intake as well. Again, if you're a heavy drinker, you should probably avoid taking higher doses of Tylenol for risk of systemic side effects too. Injections are another key point. So there's cortisone injections. That's probably the most common one. And then there's viscosupplementation injections. So the brand names that you hear are Euflexa, Synvis, Orthovix, Hyalgan, and it's hyaluronic acid, which is one of the major components of joint replacement fluid. Cortisone, again, is the most common, and that's for moderate to severe pain. You can get a cortisone shot really every 3 to 4 months. They're low risk. Obviously, anytime you stick the needle in a joint, there's a very, very tiny risk for infection. It can be painful, but it's very well tolerated. I tell people cortisone injections like putting 8 or 9 Aleve inside of your knee. So it's treating the symptoms. We don't have anything to regrow the cartilage. but it's not a cure. So again, it's a potent anti-inflammatory, and certainly you should try a cortisone injection as a first-line treatment before undertaking joint replacement surgery. Viscosupplementation, or the gel shots. It's usually a series of injection. There's one company that just has one injection, but most of these are a series. It's usually 3 of them. There's decent data for mild degenerative changes, but the data for long-term treatment of arthritis, especially once you have moderate or severe arthritis, is not very good. These also were not approved as a drug. These were actually approved by the FDA as a medical device. And again, just like we talked about the FDA approval process for the glucosamine and chondroitin, for a medical device, all that the manufacturers need to do is prove that it is safe. They did not need to prove that it is effective. They need to prove that it was safe and that it is comparable to another device on the market. So again, if you have minimal arthritis, it's certainly reasonable to try. We talked about the small risk of infection anytime you stick a needle in your joint. And there's a small risk of getting an allergic reaction. So about 1% of people, their knee can actually swell up. Sometimes they make the hyaluronic acid, some of the vendors from the rooster's comb that you hear people talk about too. So that some people can get an allergic reactions to it. I got a question from somebody in the audience asking about brand names. Are all injections the same? Synvisc, Orthovisc, or Uflex? The data is very similar for all of them for efficacy. As far as which brand that you actually get, usually it's your insurance company that has a deal with the manufacturer. So for certain insurance companies, that's going to be what you end up getting. But all the brand names are roughly the same. The glucosamine and chondroitin brands, again, they're not studied a lot. These other things are, at least the viscosupplementation, were approved as devices. So I can't comment on which of the particular brands, because they can even vary from within different brands. They don't have to be the exact same concentration, just because again they were approved as a supplement. We had one other question about anesthesia when patients' spines are blocked with arthritis. So again, most of our anesthesiologists are pretty good. They're able to get the spinal anesthetic. Even if you have a 1-level spine fusion, they're able to go above or below the fusion. Yes, there are some people that have a multi-level spine fusion, or they have bone on bone throughout their entire spine. And those patients are going to have general anesthesia. And again, general anesthesia is super safe. We do it 10,000s of times a day in this country. But those patients will certainly have to undergo anesthesia. The other thing I get asked a lot about is stem cells or platelet-rich plasma, PRP injections. They're like, well, Kobe Bryant got PRP in his knee. Can I get the stem cells or the PRP treatment? And platelet-rich, there are 2 different techniques. So platelet-rich plasma, you have to go, you get your blood sample drawn, it's spun down and they separate the platelets out and with a plasma, and they inject the knee growth factor into your joint. Stem cells, you aspirate stem cells, and it's easiest to take it from your pelvic bone because you have a lot of stem cells there. They'll aspirate. It's usually a procedure done at a surgery center. Some people can do it in the office, but it's usually done at a surgery center. You can aspirate the bone marrow sample from your pelvis, you spin it down, and then you can inject it into your knee joint. Unfortunately, the data on efficacy is minimal, and there's a reason why most insurance companies don't cover this procedure. So we're certainly studying it here at the Rothman Institute, but the data on efficacy for arthritis is minimal. Now, PRP injections for things like tennis elbow or lateral epicondylitis, I think it is reasonable. And that's actually one of the indications that's been studied on. For tendon healing, so some people are using it for cuff repairs or Achilles tendonitis. I think there's more studies on that, but certainly there's limited data on efficacy in patients that have osteoarthritis. I did get, before we go into the surgical treatment options, I had one good question on medical marijuana for post-op pain. And we asked Ari Grice, who's one of my partners who runs our medicinal marijuana clinic here at the Rothman Institute. There hasn't been a lot of data on medical marijuana specifically for pre-op pain treating joint replacement patients. But for post-op pain, there actually have been a few studies, and certainly using medicinal marijuana is safe relative to being hooked on opioids. So it's not something that I would use routinely, because most people really only need a couple days of opioids. But for patients certainly that are on a lot of chronic opioids, it's certainly been a lot safer. And I'd encourage you to talk with Dr. Grice if you're interested. Or there's protocols you have to go through, because you have to get approved through the state and get a medicinal marijuana card. But Dr. Grice has really done great work, and he lectures. He's given a bunch of these community talks talking about the role of medicinal marijuana, especially in surgical patients or patients to help minimize opioids. Now we'll go through some of the surgical treatment options. And again, the operative treatments for knee, you can get your knee scoped. And a lot of people on this call, maybe you've had a knee scope and you've had that prior to undergoing a joint replacement. We'll talk about partial knee replacements or unicompartmental knee replacements, and then total knee replacements. So arthroscopy or getting your knee scoped, the theory is, well, it's minimally invasive. You can go in and trim some of the worn out cartilage. And this is an example of a scope picture of a knee on the right. You can see at the top of the picture, that's a pothole. That's your worn down cartilage. And the theory is, if you can decrease you're running a bunch of fluid through your knee, if you can debride some of the worn down cartilage, maybe you can stimulate a cartilage type response, and that can help with your arthritis. Unfortunately, if you have a meniscus tear, arthroscopy is certainly reasonable. And if you have mechanical symptoms and your knee is catching, locking, or popping, absolutely you talk with one of our sports colleagues, and they certainly can help you with a scope. But once you already have arthritis, going in with a scope is no better than sham surgery in the literature. And they've done randomized controlled trials with this in Scandinavia, looking at this. A third of the patients get better, a third stay the same, and a third get worse, regardless of whether you had the fluid run through your knee or if you've had arthroscopic debridement. So again, the results are unpredictable at best. So I certainly wouldn't recommend arthroscopy for treatment of arthritis, and none of our sports doctors are either. Again, if you have a meniscus tear with mechanical symptoms, that's a different story. But going in just to get the cartilage trimmed isn't really going to help your arthritis. Partial knee replacements, this is one of my favorite surgeries to do. There's 3 parts to your knee. There's the inside part, the outside part, and underneath your kneecap. If you only have pain in one of the parts, so if you complain to me and you point, it's only on the inside part, or it's only on my kneecap, and your x-ray shows that you only have arthritis on one part of your knee, you can consider replacing just that one part. And there's many advantages. It's an easier recovery. It feels more like your normal knee. You get to keep all of your own knee ligaments. There's a lower risk for blood transfusion. It's a quicker operation. And there really is a good long-term track record. Only a third of these need to get revised at 15 years, which I think is pretty good. And here's some pictures of a partial knee replacement. Again, you only have to resurface in this particular case, it's the inside part of the knee, because that's what was hurting the patient. The downside is, and I tell patients this, I can't tell when and if you get arthritis on the rest of your knee. So you might come back in 5, 10, 15 years if you get arthritis on the outside part or then underneath your kneecap, and you would need to get it converted to a total knee replacement. So that's the data on the implant survivorship. But again, if I only had isolated disease on just the inside part of my knee, I would certainly want to consider a partial knee replacement, but it does have its downsides. This is an intra-op picture. Again, this is done through a relatively small incision. The main candidates, again, this is in my practice. If you only have arthritis in one part of the knee, it's really good. I mean, it's good in everybody, but in really young patients, I tell them this is a good bridge to a total knee replacement. People in their 40s or 50s that might not be able to get ready to get a full knee replacement, and you tell them, look, this will not last you your whole life, but you get to preserve most of your ligaments. You keep your own ACL, and I think it's a reasonable option for you. It's also great in our elderly patients because they recover a lot quicker, and there's lower medical complications and quicker rehab. So in my 85-year-old patients, that they can recover a lot quicker than with a partial knee than a total knee. And hopefully that might be their last surgery if they need it. But again, not everybody's a candidate. If you have an MCL tear, some people think if your ACL's out, you shouldn't get a partial knee replacement. If you have systemic disease, rheumatoid arthritis, You shouldn't get a partial knee replacement. And obesity is controversial. There's mixed data in the literature seeing if patients that are heavier do have higher failure rates. So again, talk with your Rothman surgeon about this. Not everybody's a candidate for a partial knee replacement, but it's certainly a question that you can ask. Total knee arthroplasty, and Coach K got one of these done a couple years ago, really has revolutionized the treatment of osteoarthritis. And the biggest thing that we tell our patients what we do, we help relieve pain and restore function. We want to get you out of pain, and we want to get you back to the activities that you were doing before you had an arthritic knee. Now, again, not everybody's a candidate for surgery either. You want patients to try conservative treatment measures, which is what we talked about before. Have you tried anti-inflammatories? Have you worked with physical therapy? Have you tried some exercises? Did you get any injections? And is the pain limiting you enough to be willing to undertake surgery? And the data is very good. Over 90% of joint replacements are functioning well at 10 years. These are some pictures. We're going to go through kind of the technical steps of the surgery. And we use the word replacement. It's more of a resurfacing. We don't use large saw blades and hammers and chisels to take out big chunks of bone. We're only trimming a couple millimeters of bone that's already worn away and diseased. So in this case, again, the top part's your femur, your thigh bone, the bottom part is your tibia. All we do is use these specialized cutting blocks that we trim and shave the arthritic bone off the femur. We usually cement a metal cap on the femur. We do the same thing on the tibia. We cement a metal cap on the tibia. Again, just trimming a couple millimeters of bone that's already diseased with bone spurs. And then you have a new polyethylene or plastic liner that acts as your new cartilage. Most of the time, and this is debatable too, if you have arthritis underneath your kneecap, we can resurface the under part of your kneecap. Some surgeons won't resurface your kneecap, and the outcomes are still the same. I did get one question about kneeling after joint replacement. And people say that kneeling feels weird. Everybody leaves most of your patella. If you do get the plastic resurfacing on the underneath part there, again, that's only a few millimeters. And people will say it's sometimes it's not painful, but people say it feels a little weird. So I'll try to cheat my incision a little toward the inside so you're not kneeling directly over it. But oftentimes patients could have a little numbness around the skin incision. And I do tell people they're either carpenters, bricklayers, patients that kneel at church and church pews, gardeners. You can either use some of the carpenters or bricklayers have knee pads, or you can use one of the gardening pads, one of the foam pads, just to help desensitize your knee. So again, you're not doing any damage to the knee replacement itself, but some people can say that kneeling feels weird after surgery. Now we're going to talk about some of the new technologies and new buzzwords, and there was a question about robotics that we're going to touch on as well here too. So there's a lot of buzzwords that people hear about. We're going to talk about gender-specific or the female-specific knee. We'll talk about robotics. We'll talk about navigation, patient-specific instrumentation, some of these things that you may hear on commercials or websites or social media posts. One common question I get asked a lot about is, especially from females, my female patients, am I going to get the female-specific knee replacements? And if you look at the data, so 2/3 of patients that undergo a total knee replacement are female. And that's just genetics, unfortunately, right? 2/3 of knee replacement patients are female. The implant companies look at X-ray and CT scans, and they come up with different size patients, how they fit the average patient. And a lot of the earlier studies were based on male anatomic data. So the concept is, well, if 2/3 of patients are females, can we make implants that fit a female patient's anatomy a little better? And there are some reports, and again, this is debated in the literature, that women do have slightly worse patient-reported outcomes after knee replacements. And we're not exactly sure why. We do know that they likely have a higher incidence of anterior pain over their patella after knee replacement patients. But is it because of their different anatomical differences? Men typically have, this is a picture of your knee, of your femur, and your femur bent. And the anatomy is different. So male femoral anatomy, they're usually wider and shorter, and women's knees are usually taller and narrower, like the one on the right. And some companies have developed gender-specific implants to prevent overhang. So usually they're narrow, So again, if you look at the picture on the left, again, this is the femur resurfacing part, and you can see the metal is a little bit off the bone. On the right, it's more flush with the bone. So is having a female specific knee implant, is that beneficial? So you have an in-between size option that maybe that metal doesn't rub on your tissue. And you can see that right there. The anterior flange, or the front part of the knee that you can see, again, this is the side view of the knee replacement. And that might fit your knee more anatomically. Maybe this explains why women have higher pain after knee replacement. So what does it all mean? There's more choices for the surgeon. You can get a better fit. But if you look at all the papers, there's no studies to suggest that having a company that offers gender-specific or female-specific knee implants, that they actually have better functional reported outcomes. So it certainly makes sense scientifically, but no matter what implant system that your surgeon uses, we have multiple options that we're able to tailor to fit your specific anatomy. And just recognize that even if you're not getting the knee that was marketed as the female-specific knee, there really hasn't been any studies to support any functional benefit afterwards. And we did get one question, are all implant brands created equal? Stryker, Johnson & Johnson, Zimmer, et cetera. And mostly yes. So everything that has gone through that FDA approval process, there are pros and cons. There are subtle ones to each of the different implant manufacturers. But in general, if I had to get a knee replacement, I would have no problem getting a knee replacement with any of the modern knee manufacturers. Again, I think what's more important is how your surgeon knee replacement, to a surgeon that's comfortable with their particular system, that's doing several hundred of these a year. So I would not go to my partner maybe uses Stryker or Zimmer and tell them that they needed to use the DePuy or the Johnson & Johnson knee. I would want them using the system that they're comfortable with, that they use several hundred times a year, because they're comfortable with all the ins and outs, and they're going to know how to best fit your knee replacement. So that's my comment on the different cementless knee replacements. A common one question that we get asked. Traditionally, all knee replacements are cemented. They act as a grout. But now some of the improved metals may have better ingrowth potential. And like hip replacements, most hip replacements are cementless. Maybe they will last longer. And again, we don't have 20-year data on a lot of the modern cementless knee implants, but the 5 to 10-year data is looking pretty good. And we're studying that and publishing about that here at the Rothman Institute. So that's certainly something to ask your surgeon. Again, in my practice, some people do cementless knees for everyone. And that's certainly fine. In my practice, indications, if you're a younger patient, obese patients, manual laborers that you might be putting a lot more wear and tear on their knee, they might be good candidates. So again, something to talk to your surgeon about. But again, if you look at the longer term data, there's no difference. So even if you're younger and you're a manual laborer, if you get a well done cemented knee replacement, there's again still no longer term difference. And I would be certainly happy with having a cemented knee replacement, even at my younger age. Minimally invasive surgery, we get that asked about a lot. And again, I think the most important thing, as we talked about, is going to a surgeon who's going to put your implants in the right spot. That's going to try to give you the best chance of getting a 15 to 20-year result. That's the most important thing, not the marketing stuff that we talk about. Minimally invasive surgery, it's usually done through a smaller incision. Or you hear the term a quad sparing knee or a quadricep sparing knee. I really think what's changed, and in my conflict of interest, I do a quad sparing knee, and I try to do through a smaller incision. But I'll be the first one to admit to you, I think the more important thing is the pain management protocols, and it's what our anesthesiologists that are doing with the regional anesthetic and the spinal and the multimodal pain protocol, and the rapid recovery. So having physical therapy see you, getting you out of bed a lot quicker. There are some studies that show that maybe the quad sparing knee can have earlier, you're quicker to straight leg raise, or maybe you can bend a little quicker, but there's really no difference even at earlier time intervals. And I think much more important, you go to a surgeon who's going to put all the parts in the right spot, and that you have better pain management protocols, because I think that's much more important than someone who's going to try to struggle through a smaller incision. They might take longer to do the surgery. you might have a complication with it. So I think those things are much more important. Patient-specific instrumentation, can I get a custom total knee? That's a question that I'll get asked a little bit. It was a lot more popular about 10, 15, 20 years ago. It's kind of fallen by the wayside because a lot of insurance companies won't necessarily pay for it. Yeah, usually you can get an MRI or a CT scan, and the manufacturer will make these custom cutting blocks. They take a long time, so it's not like you can book your surgery in a couple of weeks afterwards. There hasn't been shown to be any difference in outcomes, and a lot of times these cutting blocks aren't perfect, and you see a conventional knee replacement system back up in the operating room. And with some of the earlier systems, they had to get it converted to a traditional total knee replacement anyway. So it's still out there. I did do a lady with achondroplasia who was only 3'2". We had to go through the custom knee process with her just because she was so small. And she actually did very, very well, but she had to wait nearly a year to get her surgery just to get all the implants and the manufacturing process done. But certainly if you have a deformity, it's an option. The new sexy hot button topic that people throw around is, can you have the robot do my joint replacement? They're using robotic assisted total knee replacements. And I really think this has become one of the more common ones and the more popular ones that we hear a lot from a lot of our patients, because it's been marketed quite a bit. And robotic assisted total knee, you use a robotic arm like this picture on the upper right, and almost all the modern implant companies have a robot. So again, this is implant neutral, and the robotic arm helps you make the bone cuts for the knee replacement. It's used for hip replacements as well. A lot of times you may need preoperative imaging, and not all the robots are the same, but you may need a preoperative CT scan, or some people use preoperative x-rays, depending on which of the robot brands that you have. Some do not. Some just help balance the ligaments and the tension. There's certainly an added cost. And again, the data shows that it's been able to help make more precise bone cuts, which is good. But studies are ongoing to determine whether it's going to improve outcomes or not. So again, robotic total knees really have only been around for the last 5 years or so. So we don't have the data on whether these are going to last longer than the manual knee replacements or not. So this is, again, something to talk to your surgeon about. We're at Rothman, we're up to date on all the latest technology. We're the ones that are writing all the papers on the outcomes of the robotic knee replacements. So talk to your surgeon. We do have some around the area at several of our clinical sites. But again, if your surgeon does not do a robotic total knee replacement, it's not the end of the world. And I would tell you, most of my knees are still manual knees. I do still do robotic surgery as well. But I think if you're going to someone who's doing 500 or 600 knee replacements a year, that they're going to be just as good as a robot. If you go to someone who may be only doing 50 or 100 joints a year, which is none of the Rothman surgeons, all of us are doing hundreds of these a year, they might need a little bit of help. But for me, in my practice, certainly it helps make more precise cuts. It helps balance your knee. If you have prior hardware, it's great. You might not need to get a prior rod or plate taken out, but there still has not been studies to show that there's longer term benefits in outcomes or survivorship. We'll go through some of the hip options as well too. And again, just like the knee, you can get your hip scoped. It's not as common as knee replacements, people that do hip scopes. There's really no partial surgery for the hip like there is for partial knee replacements. Some younger patients, again, these would be patients under 30, maybe under 40. They might be candidates for osteotomy or different hip preservation procedures, but they're not as easy, and they have questionable results once you already have arthritis. Arthroscopy, just like the knee, you go in with a camera. You can shave some of the bone spurs. And again, the data in younger patients, again, people under 50, they can do okay if you don't have arthritis. But once you already have arthritis, there's some data that shows that hip scopes even accelerate your need for getting a total hip replacement. And certainly most patients over 50, there's data that shows that they shouldn't be candidates for getting a hip scope. So there's definitely indications if you're younger with a labral tear, but the results are less predictable. Total hip replacement, the Lancet named it the operation of the century. It really has revolutionized how we treat osteoarthritis, and patients do really, really, really well. And again, during the surgery, we usually match the implant. A lot of us use computer programming to preoperatively template the sizes ahead of time. Most of the time, we use cementless implants. In elderly patients with weaker bone, we'll use a cemented hip stem, and those patients can have pretty good outcomes if you have weaker bone or if you're getting a hip replacement for a fracture. And again, usually we'll remove the femoral head, which is already damaged, and you can see it some of the pictures below on the left. We'll then impact a socket. Some of us use screws. You don't need to, but we'll impact it with a tamp and some screws to anchor it into place. And then you use a high-grade polyethylene surface or this high-grade plastic liner. Your femur is hollow, so we usually just impact the femoral stem into the bone, and it's usually, again, a press fit technique. If you're an elderly patient or you have prior fractures, those patients are going to be the ones that we'll consider using cement. So we'll talk about some of the newer technology, some of the buzzwords that we hear in hip replacement surgery. And again, this is Bo Jackson. He had to get his hip replacement at a young age after dislocating his hip while playing football, and he still played a few years with the Royals. He played baseball with his hip replacement. His football career, unfortunately, was over. We get asked a lot about, well, what's my hip made of, or what are the bearing surfaces? So traditionally, it's a metal ball head on a highly cross-linked polyethylene plastic that looks like this. And again, it has a long track record, 80% survivorship at 20 years. It's been around for a long time. Younger patients, some surgeons will use ceramic on ceramic bearings, which is a hard on hard surface, and the wear is a lot less. So again, these are people I'm doing hip replacements on patients who are teenagers in their 20s for avascular necrosis, or if their hip is collapsed for trauma. So the wear rate's a lot less. There is somewhat high, and again, it's about 1 in 20, 1 in 25 patients. They can hear their hip squeak, and the liner can actually fracture under trauma. It's rare, but it certainly can happen. You may hear, again, you see on the news or some of the articles, metal on metal hip replacements. These are very rarely performed in the United States anymore. They did not do very well because patients do have metal ions. Some of our surgeons will do hip resurfacings. That's something we can give a whole talk on that you can talk to your surgeon about. The standard of care now, I think almost all of us are using a ceramic ball head on a polyethylene or plastic liner. So you don't have to deal with the squeaking, and you get the improved wear properties when compared to metal. So I think almost all of us are using ceramic on plastic right now. Just like the knee, you hear about minimally invasive surgery with a hip. And again, these are done through smaller incisions. You can preserve muscular attachment. They're using similar implants. And just like the knee, the data on minimally invasive surgery, and yes, I like doing cute little 3-inch primary hip incisions. And I think patients, they certainly like it. It's less of a scar. But if you look at the long-term outcomes, the most important thing is going to a surgeon who's doing several hundred of these a year, who's going to put the parts in the right spot to minimize your complication rate. So your surgeon who may struggle, who's only doing 50 hip replacements a year, who's trying to struggle through a 3 or 4-inch incision, they're going to have higher risk for fracturing or dislocation, or the cup to spin out, or some complications. So it's much more important that your parts are put in the right spot that are going to give you a 20-year result than your incision size. We get asked a lot about the direct anterior. Is that the muscle sparing approach to the hip? And you need to realize that no procedure is truly muscle sparing. And whether there's multiple approaches to the hip, there's the anterior, the most common are the anterior, the lateral, and the posterior approach. And all of these can be done through large or smaller incisions too. The anterior approach is technically difficult. There's certainly a learning curve. And again, you're a surgeon that may only do 20 hip replacements a year, who might not be comfortable with it. That might not be a good option. No procedure is truly muscle sparing. We all have to split muscles in order to get inside the hip joint. But if you go to a surgeon who does a lot of anterior hip replacements, the outcomes are comparable to all of the other surgical approaches. And again, the outcomes are great, over 80% at 20 years. Less than 1% fracture rate, 1% infection rate, less than 1% dislocation rate. So total hip replacement, regardless of what hip approach that you get, is a fantastic operation. And again, talk to your surgeon about the pros and cons of each of the different approaches, and talk to them about what they're comfortable with too. I would not go to one of my anterior approach partners and ask them, oh, all right, well, I know you do 500 anterior hips a year. Can you do a lateral hip on me? Because that I heard is associated with lower dislocation rates. I wouldn't go to my posterior approach colleagues who do posterior hips and they do it 500 times a year. Oh, I heard the anterior. That's what I want. I want that approach. You go to what your surgeon's comfortable with, what they have been doing hundreds of times a year, what they're comfortable with to give you the best outcome. So we have a couple minutes. We'll go through some questions. The biggest takeaway messages that you should get. The recent advances really have improved outcomes after hip and knee replacements. And I'll tell you that the biggest benefits are the multimodal pain protocols, the perioperative, the rapid recovery protocols that we get people up. It's a much safer surgery. We get patients out of the hospital quicker. We're doing a lot of these on an outpatient basis, especially at our specialty hospitals and our ambulatory surgical centers. All of the Rothman surgeons that you're going to see are up to date on all the latest technology and approaches. Many of us are the ones that are actually doing the research and writing the papers on a lot of these technologies, and everyone has pros and cons. So talk with your surgeon to discuss what's best for you, because every patient's different, right? It's not an assembly line or a cookie cutter operation. Everyone has different anatomy. Everyone has different goals. They want to have different activities to get back to, your surgeon should talk to you about, well, what is your occupation and what do you do for work? What are you trying to get back to? What is your if you're at higher risk for a dislocation because you have a multi-level spine fusion or a neuromuscular disease, maybe they'll consider doing a different approach. So every patient that we all talk to, their care is individualized. And that's why it's best to have a discussion, to talk with your surgeon to help you. So I'll go through a couple of the questions that I got. And again, you can kind of chime in. We'll go through a couple on the chat box too. The first one I got asked about bilateral total joint replacements. And again, that's something that you should discuss with your surgeon. So a lot of patients, if in my practice, you need to be aware that bilateral hip and knee replacements are associated with slightly higher medical complications. They do have higher risk for blood clots. And it's minimal, it's tiny. So if you're healthy, these are people in their 50s and 60s, you don't have any cardiac conditions, you don't have any conditions with your lungs, maybe you don't want to take, you don't have the time to take off work to get both of them done at the same time at different intervals, they're the patients that are going to be good candidates for bilateral replacements. I do think it's a lot from a pain standpoint. You got to recognize that too. If it were me, I would probably want to get one done at a time. But certainly it's an option. Certainly you should talk with your patient. If you've had a pacemaker and a heart attack last year, absolutely not. Just be safe and get one done at a time. But it's certainly a reasonable option if you have really bad arthritis in both of your knees or both of your hips. We got asked about age. One of the participants here is 82 years old. And again, that's something else to talk with your surgeon, right? I just saw my office today. I did a hip replacement on a 92-year-old, and he's walking around doing great at a month. And again, age is just a number. I'm not telling you every 92-year-old does great. You're certainly at 82, slightly higher risk for medical complications after the surgery. And every one of our patients, we always get preoperative labs, preoperative EKG, and everybody gets a medical clearance just to assess your risk. But certainly if you're 82 and you're in great shape, it's something to consider. And we'll of course talk with the medicine team to make sure you're appropriately optimized. But I certainly wouldn't say no just based on age alone. We got to ask, what do I do with the parts of the bone afterwards? So no, the bone doesn't grow back. Again, especially it might grow into the prosthesis if you use a cementless prosthesis. But the bone, the couple millimeters of bone is just discarded to medical waste. We got questions about gender or female specific hip replacements. Hip replacements they all come in different sizes, and we all have computer programs at Rothman with different computer templates. So we pick and choose the stem and cup that matches your anatomy the best. CT scans for everyone. So no, I don't routinely get CTs of my knee before them to be seen. Some people like, oh, do I need an MRI with arthritis? MRIs are not really helpful for arthritis. It's certainly helpful to look at soft tissues and meniscus pathology, but it doesn't help for arthritis. And there's a couple reasons. X-rays, we get them weight bearing. So all the X-rays you get in our office, you're going to be standing on your knees. So that helps look at what you're loading your hip and your knee joint with. You get your MRI lying down. So it can actually underestimate the amount of arthritis. And it just doesn't look it doesn't look at the bones as well. So another question was called tranexamic acid, or TXA. I don't know if you've heard that drug before. I didn't touch on that, but that drug has really revolutionized our blood transfusion rate. So tranexamic acid, it's very cheap. It's been around for 60 or 70 years. We give that to almost all of our patients in the operating room before we make incision, and it helps clot your blood. So it helps stop the bleeding during the surgery. The OBGYNs have been using it for postpartum hemorrhage for decades. The military has been using it for blood loss on the battlefields for decades. And it's a very, very safe drug. Our blood transfusion rate after primary hip and knee replacements are probably somewhere between 1% and 2%. So it's really, really rare to get a blood transfusion after the surgery. And that's been helpful. So that's one of the big things that's revolutionized that. What else? We'll go through some of the Q&A boxes. Stiffness. People talk about stiffness after a knee replacement. If you're stiff going into the surgery, the biggest predictor of what your range of motion after the surgery is what it was before surgery. So a lot of patients who may have a really, really bad knee and they can only bend to 90 degrees after surgery, sure, we'd like them to get more, but I wouldn't expect you to get 130 degrees of bending afterwards. So you're certainly going to work to do exercises and therapy and everything, but there's something to consider. Your wrist of stiffness afterwards if your bending is not as great before the surgery. People asked about typical recovery time. It varies patient to patient, right? A healthy 60-year-old who's a runner, runs 5Ks on weekends, they might be a little more motivated to get back quicker. I tell people mostly they're going to need a walker for a couple days, and they're going to need a cane for 4 to 6 weeks. So, and again, that's not everybody, but you make functional improvements up to a year after surgery. You're not 100% at 6 weeks, but most people are able to get around with a cane as long as they don't need a cane for anything else, if they've had back issues or balance problems. So the other questions we got, robotic procedures being less invasive and shortening recovery time. There's really no data on that. And again, in my practice, my incisions are smaller with my conventional technique. My robotic incisions are actually a little bit bigger, and they both do the same. So I don't think that either incision size or using robotics will make you have a shorter recovery time. I do think, again, the proponents of robotics will argue that if you can make cuts more precise, maybe it will last longer and it'll last you have higher survivorship at 15 or 20 years. But we just don't have that data yet. Also got questions about limitations after knee replacement, jumping or squatting. So again, most people can jump and squat. Your motion might limit you. I do tell patients I wouldn't want to. People that are I wouldn't want to run a 5K every weekend. I don't want you skydiving. Patients that are skiers, skiing's not going to do any damage to your knee replacement. But if you fall and you have a bad injury, yeah, I mean, you could dislocate or get a fracture around your implant. So I just tell you to be a little bit careful. We have a couple more. I want to be respectful of people's time. I was asked about diagnostic equipment to determine arthritis in hip joints. So the best test is X-ray. So again, we talked about why weight-bearing X-rays are important, and physical exams important, right? To talk to your surgeon. We actually do. I mean, telehealth was great during the pandemic, but we do physical exams on patients. So usually people that have issues with their hip and hip arthritis, they're going to have limitations with range of motion. Their hip's going to be stiff. They're going to have difficulty putting their socks on. They're going to have difficulty putting shoes on. They're not going to be able to bend as much. They're going to have trouble getting out of a car or doing stairs. And if those are buzzwords that are limiting your activities, that might be time to talk to one of your hip replacement surgeons. Another good question talked about BMI and eligibility for knee replacement. So if you're not aware, body mass index is one measure of obesity and weight. The big issue with operating on patients who are obese, and usually we'll use a cutoff body mass index over 35 is considered. If you're over 30, you're obese. If you're over 35, you're morbidly obese. 40 is a really, and I don't have any cutoffs in my practice. But you do need to understand that if your body mass index is above 40, we know there's studies that show that you're 7 to 8 times more likely to have an infection than if your body mass index is below 35. So the infection rate starts going up at 35 and it goes up exponentially at 40, and you do not want to get an infection. So most patients that come to my practice whose body mass index is over 40, we'll talk about weight loss. We'll talk about portion control. We have a dietitian on staff who's willing to talk with you. If the people that are above 50, you can certainly talk with some of the bariatric surgeons that we partner with. And I'm not recommending that. There's pros and cons with that too, but you should try to make an attempt at losing some weight. I don't have a scale outside my room to tell you if you're 40.1, you're not getting surgery. If you're 39.9, but there's certainly high risks, and you need to understand that having an infection is a really, really bad problem. And being able to lose a little bit of weight is going to help your knee last longer, and it's going to help you feel better if you're able to do so. So that's my comment on body mass index or BMI that we talked about. So again, I don't want to run too much out of time because I've gone about 5 minutes over here. I think we've gone most. I'll talk about physical therapy. That's going to be the last question that we talk about. So physical therapy, we've done a lot of studies on this. So we love our physical therapists. We work very closely with them. Some people need to do physical therapy afterwards. About most of my hips, about half of my hips do not, maybe a quarter of my knees do not. And therapy, everyone's doing exercises. We have a home program. We have printouts. We have an online module that patients can follow. Some people want to work with a therapist that want to work on somebody that's going to work to bend their knee and do exercises. Some people are able to do stuff on your own. And I think that's more of a personality thing. If you come back to my office and you're only bending at 80 degrees, yeah, you need to go to physical therapy. If you're elderly and you need to learn how to walk and work with somebody, absolutely. They're going to work with you how to wean yourself off your cane or your walker to work with balance. Some people, they're able to do exercises and walk on their own. And that's certainly reasonable too. So it really depends. It's specific to each patient, how much time you have. Some people are busier than others. So again, that's something to discuss with your surgeon as well. So I hope you guys, you learned something. If you have any questions, again, Natalie is putting our phone number. You can go to rothmanortho.com. You can give us a call to discuss. And again, these aren't specific to me. One of the big parts that I like being about, the best parts I like being about being a part of the Rothman Institute, right? We all follow the same evidence-based protocols. We may do things different technically, but we're all the ones that are at the forefront of all these new technologies, whether it's the robotics or the minimally invasive or the patient-specific instrumentation that we talked about. And we're the ones that are writing the papers and helping give the talks on these different subjects too. So again, thank you guys for all chiming in. Hopefully you learned something. Give us a call if you want to speak with us.
Yeah, thanks everyone for attending. And I did put our website and our phone number in the chat box. You all have my email. Feel free to reach out if you have any further questions. And we did record this presentation and it will be sent out to all those who registered and attended within the next week. So have a great night, everybody.
Thanks again, everybody.
Thanks,
have a good
Dr.
night.
Courtney.